Thanks very much, Caitlin. Thanks for this opportunity to present the case for stereotactic radiotherapy. And it's nice to be not only speaking in front of my friends and colleagues in the nursing profession, for whom I have such respect, but it's nice to be actually debating a nurse rather than one of those testosterone fired up surgeons. So we're doing this as a tag team, Melissa and I, and neither of us have anything to disclose. Well, to open the debate, I'm going to tell you how we actually do SABR. SABR stands for Stereotactic Ablative Body Radiotherapy. You may also know it as Stereotactic Body Radiotherapy or SBRT. It doesn't matter, they're both the same thing. But it's a very new technology, it's a high precision technique. And what does it involve? Well, it involves very high doses of radiotherapy. In fact, modelling suggests that the doses are 6 times the standard dose that we use for treating a more advanced stage of lung cancer. So it needs to be very accurate because the risk of doing something harmful to normal tissues is very high. It's done as 1 up to 5 treatments. So it's extremely convenient. They're very high doses, but they're given in a short number of treatments, and this is convenient not only for the patient but also for the department, which may have a heavy workload. We do it by using multiple beams and arcs, and I'll come back to this, and this way we can minimise the dose to the normal tissues and maximise the dose to the cancer. But we need to know exactly where the cancer is. We have to be able to confirm the location of the cancer immediately before we treat the patient because we don't want to irradiate the normal tissues unnecessarily. We call this image-guided radiotherapy, and we actually do it not only at the beginning of the treatment but halfway through the treatment and more often as necessary. And we do it every treatment because we know where the cancer was on Friday may not be where it is on Saturday. And it's absolutely revolutionary. It's completely different to how we've given radiotherapy in the past. Lots of treatments, 30 or 35 treatments over 6 or 6.5 weeks. This is 1 or 3 or 4 treatments given over 2 weeks. And the traditional science that underpins conventional radiation does not apply in this situation. So because it's a high precision technique, we need to be confident that the patient is in the same position throughout the treatment procedure. And one of the ways we can do that is to make a specially fitted cast and then put a drape over the patient and then evacuate that, produce a vacuum, and this enables the individual to hold a fairly steady position throughout the treatment, which in our case takes, in our institution, takes from 45 to 60 minutes. We give the patient some lorazepam beforehand so they can relax, and a number of the patients actually do fall asleep during the treatment procedure. The second thing we need to take account of is not just the external motion, the patient motion, but the internal motion. That's the motion of the cancer during the treatment. If we take a PET scan, and you can see this is a conventional PET scan, the cancer appears as a sphere, but this is a standard PET scan. But if we actually map the position of the cancer during the process of ventilation as the patient's breathing in and out, we in fact see that the shape of the cancer is no longer a sphere, it is now more like a cigar. And if we were just to treat the sphere with this high-dose technique, we may miss the cancer when the patient inhales and the cancer moves in a downward trajectory. So it is absolutely essential that we take account of motion, and we do this by using 4D technology, not just 3D, but taking into account time as a factor determining where the cancer is. And this is what I mentioned before, image guidance, and this is, there are many ways of giving stereotactic radiation. We do it with a linear accelerator. They're all probably pretty much the same. It's just like whether you drive a Honda or a Toyota, they'll both get you from A to B. There's no great difference, but the way we do it is with image guidance using, this is where the beam of radiation emerges from the treatment machine, and attached to this machine is a CT scanner. So these are the elements of a CT scanner, and we can actually rotate the machine around the patient while they're on the bed and image the cancer immediately before deliver treatment. And here's an example of the image guidance. So this is the cancer that I want to treat with a margin around it. You can see the cancer sits neatly inside that pink contour. But when we do the cone beam CT or the CT scan immediately before treatment, you can see it's not the same quality, but it's good enough to localize the cancer. We can see the cancer actually lies a couple of millimeters outside the contour. So what we do is we can remotely shift the couch on which the patient's lying and shift the cancer back in so that it lies precisely within that pink image. And we can do that with sub-millimeter accuracy. So this is a very high precision technique. And then once we're confident we know where the cancer is, we can deliver the treatment, and we can use, in this case, arc therapy or multiple beams. And you can see that the beam actually rotates around the patient, and each beam just treats the lung for a portion of the rotation, whereas the cancer, which is this blue sphere here, is being treated throughout the rotation. So the lung gets only a fraction the dose of the cancer. So now I'll pass over to my debater, my opponent, Melissa, and she'll give you an explanation of surgery, and then we'll come to the evidence.
Thank you, Caitlin. So the other local treatment for lung cancer is surgery. And what we're going to talk about, just like Dr. Ball just did, is how we do it in surgery. So we're going to talk about treatment guidelines, staging and fit for surgery assessment, surgical approaches, extent of resections, and preventing and managing toxicities, which we have just a few. So the decision for recommending treatment for early stage lung cancer is largely based on well-established national guidelines based on available scientific evidence. Currently, surgery remains a standard of care for early stage lung cancer in the United States. The European Society for Medical Oncology has clinical practice guidelines by which treatment decisions are made for early stage lung cancer. ESMO recommendations for early stage lung cancer patients are: number one, surgery should be offered to patients with stage 1 and 2 non-small cell who are willing to accept procedural related risks. SBRT or SABR for early stage peripheral lung tumors is associated with low toxic effects in patients with COPD and the elderly. These recommendations are considered grade A, backed by level 3 evidence, which is prospective cohort studies. Once we have established a radiographic extent of disease workup and confirming what appears to be an early stage lung cancer, just went ahead of myself. We have quite a bit of homework to do before we actually consent a patient for surgery. The mediastinum is staged by either mediastinoscopy, or more commonly now, we're staging the mediastinum with EBUS, which is much easier on patients and has a very high degree of accuracy. If we do confirm that there's no evidence of lymph node involvement, the next decision we have is to determine the extent of resection. Based on where the tumor is located, whether it's peripheral or central, if it's approximated to the fissures, we decide the extent of resection. Other clinical considerations are what a patient's pulmonary function is preoperatively and what we expected to be postoperatively. In addition to that being medically fit for surgery, we take into consideration, close consideration, of patient's cardiac function as well as other comorbidities. Sublobar resection, which is anything less than a formal lobectomy for clinical stage 1 non-small cell lung cancer in the United States. A national database study was published in 2016 comparing lobectomy to sublobar resection of nearly 40,000 patients. And this analysis showed that lobectomy did prove superiority over sublobar resection, 66% versus 51% respectively. So once we've decided the extent of lung that we're going to need to take in order to treat a patient with curative intent for lung cancer, we need to decide the approach. Posterior lateral thoracotomy was years ago the standard operation by which we would perform pulmonary resection. And having worked in thoracic surgery for the past 30 years, I've lived through the advent of minimally invasive surgery for lung cancer. Smaller incisions and improved pain control have truly revolutionized what we can offer patients as far as surgery and how quickly we can get them back on their feet. So in addition to posterior lateral thoracotomy, which we rarely do for an early stage lung cancer, most surgeons are now minimally invasive savvy, and we either perform video assisted surgery through 3, 2, or 1 port, or now the robotic assisted surgery termed RATS, which I think is terrible. It's 5 ports, but we're able to get patients out of the hospital sometimes postoperative day number 1. Surgery does have a few more associated toxicities, or as we call them, risks and complications. Trends in the United States are looking at both 30 and 90-day mortality as measures for centers of excellence and insurance reimbursement. So it's something that was scrutinized rather closely in the United States. How often we have patients readmitted to the hospital, how often we have patients develop postoperative pneumonia, atrial fibrillation, which is a big problem for us, the development of deep vein thrombosis, pulmonary embolism. So we have a whole host of problems that we battle against in the postoperative period. So in that note, patients can have a masterful operation, and once they roll out of the operating room, as a surgeon I work with says that's when the work begins, and that's where thoracic surgery nurses really play a vital role in getting patients safely out of the hospital and managing those toxicities. So the trend internationally is to better prepare patients for surgery in an effort to minimize these postoperative risks. My work at the University of Maryland is a multidisciplinary pilot study that we have ongoing now, looking at better preparing our patients to know what to expect in the postoperative period and physically preparing them before surgery. Another trend nationally and internationally are what are called enhanced recovery after surgery. This started in colon cancer and now has moved into the thoracic surgery realm. And what these pathways essentially do are re-examine traditional practices and replace them with evidence-based care. And what we're seeing with these advanced recovery protocols is that we're able to see far less toxicity, better outcomes, and decreasing length of stay for our patients. Professor?
So thanks, Melissa. We'll now come to the scientific evidence for SBRT or SABR. And the first question is, we know we can deliver it and we know we can deliver it safely, but is it any better than conventional radiation? And this is the first trial which compared SABR treatment with conventional radiation. It was a Scandinavian space trial. And as you can see from the survival curves, there is no difference between the two treatments. The authors of the study therefore concluded that SABR is the preferred treatment for patients who have inoperable non-small cell lung cancer because it's much more convenient. It only requires 3 treatments in this particular trial as opposed to 35. So who would choose 35 treatments when they could achieve the same outcome with only 3 treatments? Now, there are several weaknesses of this trial, and the first is that not every patient had a diagnosis established histologically, and that's because many of the patients who are inoperable are not fit enough for the procedure which is required to establish the diagnosis. And also in this study, a third of the patients were not staged with PET scanning, which we would regard as the standard level of establishing that the disease is localised to the lung and hasn't spread to the regional lymph nodes or other parts of the body. So we decided to do a similar trial in patients with inoperable non-small cell lung cancer. And in our trial, which we called the Chisel trial, we determined that all patients would have histologic confirmation of the diagnosis and that all patients would have staging done by PET scanning so that we knew that none of them, or that they were unlikely to have hilar or mediastinal lymph node involvement. Patients were randomised to have on your left 54 Gray in 3 treatments or 48 Gray in 4 treatments in 2 weeks versus having 33 treatments of 66 Gray or 50 Gray and 20 treatments in 6.5 or 4 weeks respectively. Now, I'm presenting the results of this trial tomorrow at 11 o'clock, so if you want to know the results, you have to come along to that. Another way of doing it is to actually sneak a look at the abstract book. But I'm not going to tell you today. I'm keeping my powder dry to tomorrow. But I think the results are quite exciting. So we've been talking about patients with inoperable lung cancer who have normally been the patients who have come our way because they're the surgeons they're the patients that the surgeons don't want to operate on. And generally speaking, they have a lot more comorbidities and problems and are more likely to run into the post-operative complications that Melissa's described. But is there evidence that SABR may be as good as, or if not better than, surgery? And this is a publication from the Lancet Oncology just 2 years ago. And this is the composite of 2 trials. So 2 trials were conducted in which surgery was compared with SABR for patients with non-small cell lung cancer. Unfortunately, both trials had to be terminated early because they could not recruit patients. It's a very difficult decision for patients to make. I'm putting my hands in the, putting my life, if you like, in the under the control of the computer, which will decide whether I have surgery or radiotherapy. And so they only recruited in these 2 trials 58 patients, which was probably not adequate to answer the question with certainty. Nevertheless, it is the only randomised evidence that we have comparing SABR with lobectomy for operable stage 1 lung cancer. And what you can see here is that the survival of the patients randomised to SABR is actually superior to the survival of the patients randomised to surgery. The lung cancer control in both arms was exactly the same, so the difference related to complications related to the surgery. So in my view, if any patient is marginal for surgery, they should be considered for SABR. However, a caveat to make in relation to the study is that the data really only go out to 3 years, and we don't know what the 5 or 10-year data are going to look like and whether this difference is going to be sustained. Nevertheless, it's very suggestive that SABR may be a comparable and maybe even better treatment than surgery. Now, we've seen a similar sort of experience in patients who are treated for oligometastases, in other words, cancers that have metastasized to the lungs and which have traditionally been treated with surgery, with metastatectomy, in other words, trying to turn the disease into a chronic disease, even though it's metastatic. And this is non-randomised data from the Netherlands, which compares surgery with SABRE, and you can see that the outcomes are very similar. Now, the beauty of SABRE is it is extremely well tolerated. Patients, apart from the discomfort of having to lie still for an hour or so, are amazed that the machine has actually been turned on and that anything has happened. Some will complain of mild fatigue, but many could go home and conduct their lives exactly as if nothing had happened on the day of the treatment, although they may have the residual effects of lorazepam in their system. But if they wanted to go shopping, if they wanted to go out to dinner, there is no reason why they cannot. But one needs to add a note of caution, and that is that with these very high doses of radiation, again, this is a technique which has treated a patient of mine who was on the Chisel trial, I should add, with a lesion in the left lower lobe. And we can see 5 years post-treatment that we have this very dense fibrosis, very difficult to distinguish, in fact, from recurrent lung cancer. And there have been many publications on how to develop algorithms to distinguish recurrent disease, which might require further intervention as opposed to just scarring from the radiation. Now, most patients who develop this problem, in fact, don't have symptoms from it. But if the patient has pre-existing interstitial lung disease, then, as with conventional radiation, fatal pneumonitis toxicity has been described. So we would say that this treatment is not suitable for someone who's got pre-existing interstitial lung disease. The other thing that we've learnt, and we learnt relatively early in the piece, and this is work from Bob Timmerman, who's one of the leading figures in the US in the implementation of SABRE, is that if you treat cancers with this technique and the cancer is adjacent to the major airways or major vascular structures in the mediastinum, then your risk of toxicity increases. So these are the patients who had central cancers treated with SABRE versus the patients who were treated with more peripheral tumours, which were at least 2 centimetres away from the mediastinum, and the proportion without toxicity is much lower in the peripherally treated tumours. And in fact, 6 patients in this study died as a result of complications. And this is the sort of complication you can get, and this was actually a case report in the New England Journal of Medicine. Very unusual to see that in the New England Journal. But the significance and importance of this event, where the wall of the trachea necrosed, fell apart, and the patient died of a massive hemoptysis, is an indication that if you're going to give SABRE to a central tumour, you should exercise the greatest caution. People do believe in it. I think there are alternatives which are much safer, and I'm not prepared to accept death as a result of treatment when there are other potential treatments. So I would summarise by saying, what should the ideal cancer treatment look like? It should eradicate the cancer, that's obvious. It should be free of toxicity, and unfortunately we can't say that for the vast majority of cancer treatments that are available today. It should be convenient and allow people to get on with their lives as if nothing had really happened, and it should be cheap. And SABRE ticks all the boxes. So thank you, I rest my case.
Well, we're not going to use that checklist for surgery. I think we eradicate the cancer, but we don't measure up. Oh, you forgot this slide. Get back up here. You're so excited about beating me.
But we do believe that the evidence is still incomplete. There's just that one composite of 2 randomised trials. So my colleague Shankar Siva and I were asked to write an opinion piece for the oncologist, which we entitled Curing Operable Stage 1 Non-Small Cell Lung Cancer with Stereotactic Radiotherapy. The Force Awakens. And this got into the Twitter sphere, and someone said, best title ever. So Curing Operable, The Force Awakens. So we are an awakening force, and I think we will be going head to head with the surgeons, and Melissa's going to describe how we're going to do that now.
Okay. So evidence for surgery. This meta-analysis of SBRT versus surgery, published in 2016, essentially showed that there's no difference in overall survival at 1 year and 3 years when comparing SBRT and surgery for early stage lung cancer patients. So how can we obtain level 1 evidence to answer this question? The issues associated with randomization into clinical trials comparing 2 different treatments is difficult, and it is especially difficult when one of those treatments involves surgery. Surgeons struggle with maintaining equipoise. Offering and performing surgery requires commitment and belief in your surgical plan. There are multiple variables in surgery that make it very difficult to maintain complete consistency, which is more successful in SBRT. The variables are surgeons, the team, the patient, and the postoperative care. The nature of surgery, as opposed to a drug trial, complicates the process of informed consent in a randomized trial. Conventionally designed phase 3 trials have been attempted internationally, all failing to adequately accrue, primarily due to patient refusal to accept randomization that would assign them to very disparate treatments. The ACOSOG Z4099, which compared sublobar resection with stereotactic radiation for patients with stage 1 non-small cell cancer. And again, this study was terminated due to poor accrual. There was difficulty in getting surgeons to refer the patients to the study and agree to randomization. As well, it was difficult for patients that wanted their tumor removed to agree to randomization. As Professor Ball discussed the SARS and the Roselle trial. Both studies closed to poor accrual. We were able to glean some information by pooling the data from both trials, and there does appear to be an overall survival favoring SBRT over surgery in this particular trial. How we are going to look to overcome that the randomization dilemma in surgery trials, comparing them to SBRT, is an ongoing international study right now called StableMates. StableMates is a randomized phase 3 study that will look at high-risk patients with non-small cell lung cancer. The interesting part of this study is that it's going to use what's called pre-randomization. And pre-randomization is patients are evaluated for their eligibility for the study prior to talking to the patients. And once it's determined that they are in fact eligible for participating in the trial, the central study center randomizes them. Then the patients are approached with their randomization selection. This allows patients to maintain a control over their situation, and they don't feel like they're being set up for a flip of a coin to determine their cancer treatment. If patients disagree and they don't agree to the randomization decision, they can go on to be treated by their team as a standard of care, whether they choose radiotherapy or surgery. Currently open in a little over 30 hospitals, with more on the way. Over the past year and a half, the study has enrolled 44 patients. So it's not as slow to accrual as Roselle and STARS were. So we're very hopeful that this, in fact, will answer the question that we've all been asking for many years about the comparison of these two treatments. So the take-home message, and in conclusion, considering clinical trial options prior to initiating treatment is key to supporting clinical trial enrollment and ultimately gaining that level 1 evidence needed to answer this question. Multidisciplinary care is critical for this patient population, as we know, and multidisciplinary team review at weekly tumor boards prior to discussing treatments for patients, and then continuing to talk to them afterwards is critical. Oftentimes patients have come to us for surgery, and they're not ready to hear that there's other options. So I think it's critical that we review these patients as a team prior to offering them treatment. And then also educating patients and their caregivers as to the role and importance of participating in clinical trials and gaining the scientific evidence that we need to make sound recommendations for treatments. Not just doing what feels right is critical to move this effort forward.